Good afternoon. Thank you for having me here today. I'm Scott Shipman. I'm the Director of Clinical Innovations at the AAMC, the Association of American Medical Colleges. When some people hear the term AAMC, they think just medical education. I actually sit in the healthcare delivery side at the AAMC, so focus on academic health systems and the delivery of care. And I have the privilege today of talking with you about eConsults. You'll see at the top of this slide the word CORE. We lead a project out of the AAMC called Coordinating Optimal Referral Experiences. eConsults are a key part of the CORE model, and I'll be referencing some of our findings from the CORE project. We now work with about 27 academic medical centers around the country who have implemented this model, starting off with 5 institutions as our pilot through a CMMI Healthcare Innovation Award that ended in 2017. So looking at the drivers of demand for time and visits for cancer care, certainly active cancer patients and cancer survivors, as we've talked about today, take up a significant amount of the time of the oncology team and the oncologist. In addition, referrals coming in, new patients coming in to clinic are a substantial portion of the work. And then curbside consults, while rarely quantified, I think any oncologist would recognize that the in-basket messages that we heard about from Dr. Levy, the phone calls, the pages, the getting stopped in the stairwell, all of those add up as well as a demand on the time for the oncologist. So let me level set in terms of what I'm talking about with the term eConsult, because there's a lot of E things around these days. An eConsult is an asynchronous exchange between two providers. Asynchronous meaning it's not a video exchange, it's an exchange over time between these two providers, and it's not patient to provider, it's two providers interacting with one another. The eConsult enables the requesting provider to manage the patient guided by the recommendations of the consultant. So the eConsult is often used in a situation where the caring provider has a question but doesn't believe they need to actually send the patient off to be seen by the specialist, but needs the specialist's input to make sure they're taking the right next steps, whether it's for evaluation or management. eConsults can be built into the EMR in the CORE model, the one I mentioned that we run. We do build the eConsult into the EMR, which we think is an important premise because that's where clinicians are spending their time, albeit not happily. They're spending their time in the EMR disproportionately. It's also possible to build eConsults in a cloud-based platform, and there are vendors out there that offer eConsults through a cloud-based platform, which has the advantage of getting around the interoperability limitations of EMRs, but the disadvantage of having to go somewhere else to send that question. The eConsult really formalizes the process and expectations around an exchange between providers, and in that respect is much better than the typical curbside, where the information that's exchanged is often partial or variable from one patient and provider to the next. The timing of the curbside is often inconvenient for one provider or both. Documentation of the exchange is rare with most curbsides. Those in-basket messages that were referenced earlier don't stay in the medical record, whereas the eConsult becomes a permanent part of the medical record. Not most importantly, but certainly important for buy-in from clinicians, the eConsult enables clinical credit, an RVU credit, to be given to the provider for providing their clinical expertise. In fact, in the CORE model, we set it up where both the sending provider who's owning this problem and not just punting and sending the patient off to the specialist, and the responding provider both get some RVU credit to recognize the clinical work that they're doing. Why do eConsults? Well, eConsults have been shown to improve access to specialty care. They reduce marginal value referrals. They create a meaningful connection between providers, provides a better patient experience, and it's cost saving. And in the interest of time, I might just touch upon each of those 5 without showing you detailed slides, but I can come back to slides at the end if there's interest in diving deeper. With our pilot with the CMMI grant with 5 institutions implementing this model across really all their medical specialties plus a handful of surgical specialties. We found that access to specialty care improved by about 84% across the board, defined as timely access, meaning within 14 days of the request, patients were able to get the specialty input that their providers had requested. Reducing marginal value referrals. The core model implemented with those first 5 sites was pretty much exclusively primary care to specialty care. And we found a 16% reduction in referral rates by primary care providers who used eConsults at greater than median rates relative to their peers. Creating a meaningful connection between providers. We mostly have qualitative data, some survey data on this as well. Perhaps one of the hidden nuggets about this is the connection that eConsults enable between providers who otherwise don't interact anymore. It's very rare for primary care providers and specialists to have opportunities to interact in patient care and get together. The eConsult, while imperfect relative to the old days where we got together and knew each other well, does provide a real connection between providers that showed benefits both to the resilience of the providers as well as the effectiveness in clinical care of having better tools for communication. Better patient experience. Patients really find the eConsult to be favorable in most cases. We always say that if a patient wants to be seen, then the referral should happen. This isn't a means of rationing care, but most patients, given the choice of a quick turnaround of 3 days or less, in most cases 1 day or less, for specialist input, as well as not having to take a half day off of work, not having to travel, not having to park, and all the other things we've heard about, find that a good opportunity for them. And cost savings, we saved for Medicare in the 3 years of the project about $8 million just from the reduction in specialty visits over the course of that time. Briefly, how it works, the primary care provider in the classic model sends the eConsult. The specialist averages about a 24-hour turnaround for answering the question. The specialist always has the opportunity to say, I can't answer this question as an eConsult, I need to see the patient. That can be effectively just converted into a referral, so the documentation that's already been done serves as the documentation for the referral. Can get into more details on that if people are interested. About 85% of the time, eConsults work as an eConsult where a subsequent visit with the specialist isn't needed. Roughly 15% of the time, there's a conversion to a referral. Increasingly, we have specialist to subspecialist use cases for eConsults. There's no reason it needs to be limited to primary care. In addition, we have some situations where specialists take over as principal care providers, much like in the oncology model when a patient is undergoing active cancer care, where the specialist reaching back to the primary care provider is a use case that some institutions are exploring. I will not go into these details, but have them as backup slides if people want to dive deeper into our findings. I will just add at the end that we were happy to see that after a lot of advocacy by my colleagues at the AAMC and others around the country, CMS in 2019 is paying for eConsults for the first time. They've approved a coding structure for both the sender of the eConsult and the responder to the eConsult, much as we've had it in the core model. Which we think will help to generalize the use of eConsults, and commercial payers are rapidly coming on board as well. Thanks.